Hello, good morning, and welcome. I'm Anil Gudi, and I think today we'll give a short talk on poor responders. And let's see. I'll give you some of my concepts and see how it works. Thanks a lot, Sachin and Sherry. It's always good to get up in the morning on a Sunday to talk on these topics. I know in India people love to come on Sundays. Here it's a day where we end up waking up late, but with the aging process, I can't. So let's look at poor responders. The question is, can poor responders be treated effectively? Now, if you ask anyone, they'll say, I know how to treat poor responders. From a marketing perspective, from a scientific perspective, they'll say, I know a way to treat poor responders. Have a look at research, and there are tons and tons of treatment. What does that mean? That means that there's no clarity, and we know that treating poor responders is a phenomenal challenge. So what are the general techniques? We'll say, let's look at mild IVF, natural IVF, screening of embryos, endometrial scratch, and we looked at multiple ways of modifying and trying to improve results. So years ago, a breakthrough came, and that was about DHEA. Now, if you ask any gynecologist, does DHEA work? And he'll say, yes, it does. But what is that evidence? That evidence is very much biased on observation and biased on what we feel. Now, the reason why research is a big question mark is when Gleischer started this study, he took 28 patients and he gave DHEA 75 milligram for 18 weeks, and they found an increases in oocyte retrieval, fertilized eggs, embryos, nothing to do with pregnancy. And then what ended up happening is that the RCT was cancelled because everyone was demanding, and it was unethical to continue. After that, research has not yet been focused on live birth rates. There have been some research that has said that yes, you can get more eggs, but there's a big question mark on how good it is. Then they looked at testosterone implants. Again, if you scan the papers, you'll see that there's some evidence that testosterone implants may work, which means androgenizing the follicles. What is the concept? The concept basically is that women, as they grow older, lose their androgens. As you lose your androgens and your LH starts going down, adding androgens may help in the recruitment process. And that is backed generally theoretically by increasing androgens. But it's again not really proved. Adding letrozole again, they did not find much evidence in improving the chances of pregnancy. People started adding LH because they thought as women get old, truly so, LH levels decline, and adding LH was better. Increasing FSH dose, adding aspirin, Viagra, and nothing really seemed to work. Do you add clomiphene in poor responders? That's been tried too. Again, that's not worked much. Growth hormone was there in the 1990s. It's making a comeback now. And I don't know how much of you all have read about growth hormone in IVF. Its evidence is very, very limited. Its evidence is not about generating more eggs. It's about increasing follicle size. And its linkage towards decreased IGF-1, and it seems to work there. And again, at present, I don't see an evidence. It increases the cost of IVF whenever you try and do it. The evidence is not there. And then, well, people said, let's do natural IVF. And the concept that in natural IVF, you are able to choose what nature has given. And that made sense, doesn't it? You think, well, nature gives the best follicle, and let's try and recruit that follicle there. And they did one of the largest reviews of 2 decades of natural IVF. And what they found out that the live birth rate in an unstimulated IVF was around 4.7%. And that's phenomenally low. So I would say, well, let's look at the data of natural IVF. When people say natural IVF works, I'll say, let's look at the data. The data doesn't match up. So if you are going to tell someone that I'll do natural IVF, I don't think we have a data to suggest that it makes a good difference. So what is the challenge in poor responders? Now the concept, what we believe is that oocyte and age are beyond repair. What the ASRM says is that the provision of futile treatment is not ethically justified. And in fact, there may be no effective treatment for poor responders. Now, if you use your normal protocols and you said, let's start stimulating, let's do a long protocol, then that statement works. If you're, to a certain extent, not going to start moving away from traditional protocols, you really can't treat poor responders much. And what patients will end up doing is they'll end up switching doctors, moving from one doctor to another, till somebody gives them more promise, or eventually when they head towards egg donation. The only effective treatment is to lower the female age. Now, if anyone of you all knows how to make ovaries younger, because women don't get old, ovaries do. And that's one way to treat them. So let's go back to the basics. And we say, if we want to give someone a better chance, we need to get more eggs. Can we get more eggs? And that is based on understanding, one, the ovary, understanding what you're treating, and also understanding how the woman recruits follicles, and on the basis of that, probably you'll be able to help some women. Remember, you'll always be able to help some women and some you won't. Now, the general accepted rule is the more embryos you replace, the chances of pregnancy will always rise. Which basically means that the more eggs you get and the more embryos you have, cumulatively you'll get a better chance. If you look at egg numbers and live birth rates, once you start crossing around 10 to 15 eggs, it doesn't make a huge difference. The question is, can you get to 10 eggs or not? If you can't, then again, you are stuck. If you again look at normogram and calculate live birth rates, you're, even at a young age, once you start crossing between 7 and 8 eggs, it doesn't make a huge difference. And as you start getting older, what you want is between 12 and 17 eggs. Now, if you can't get 12 to 17 eggs, and this is what I often tell patients. I tell patients that if you are going to get 1 or 2 eggs, then you're going on this lottery where you may get 1 normal embryo sometimes, which means that if a woman produces 1 or 2 eggs and needs IVF for factors other than low reserve, then you are effectively asking the patient that you may undergo 10 rounds of IVF, and we may end up still not giving you more than a 40% chance of pregnancy if you're producing less eggs. So in the past, they had the Bolongo criteria, which basically is quite old. It is basically what we have seen now is 2 of the 3 features: advanced maternal age, previous poor response, and abnormal ovarian reserve, or 2 episodes of poor response after maximal stimulation is enough to define somebody as a poor responder. So what is the problem with this classification? It did not classify somebody as a young poor responder and an old poor responder. And why is it important? That age is the best test of quality. So if you're able to get a reasonable number of eggs in somebody who is young, and again, defining young is something which is controversial because aging process varies between Indian women and Caucasian women. So Indian women will start aging in the early 30s and Caucasian women will start aging in the late 30s. So you'll see a lot of women at 32 and 33 with the low AMH, and we'll see a similar number of Asian women who will have a low AMH at 31 and 32, while many of women at 35 and 36 in the Caucasian group will do that. So the Poseidon group came up. And why is the Poseidon group important? The Poseidon group important because it allows you to classify patients, but equally it allows you to focus on some patients who can have a good outcome. And I'll tell you why. So you've got Poseidon 1 and Poseidon 3. What are Poseidon 1 and Poseidon 3? They're both about young patients. Poseidon 1 is a patient where your interventions may need to be reviewed. The reason is these are young women with a decent ovarian reserve, and unfortunately there is an unexpected or a suboptimal response. And we see it always. You have somebody with a normal AMH, she produces 4 follicles. Why? Then you subgroup them into 1A, where you get less oocytes, and when you get 4 to 9 oocytes after standard ovarian stimulation. Group 3 is the same, young women with a poor ovarian reserve, less antral follicles, and a low AMH. So what do you learn? What do you learn? That from group 1, you'll have to seriously look at your protocol. Group 3, you will need to get more eggs and you'll have to devise mechanisms. Then look at Poseidon 2. Poseidon 2 is women who are older with an adequate ovarian reserve. Again, similar to group 1, but women who are older. And Poseidon group 4 is women who are old, who have a poor ovarian reserve, and whose stimulation parameters on ovarian reserve are low. So have a look at this picture. Who should, you see somebody and said, in which cases can I give a good result if I change the protocol? It's group 1. In which cases will you get more eggs but may not get a good outcome? Group 2, because they're older. But in a group 2, you should be able to encourage the patient and say, see, you have a good reserve, you're older, you may need more treatment. Group 3 is someone where you'll need to adapt to different protocols and alternative protocols to get more eggs. And group 4, I think you need to be very frank with someone and say, it's very unlikely we'll be able to get to a large number of eggs, and you'll need to balance and say, when do you move towards egg donation? And so this is again a more simplified version. Group 1 and group 2 are young patients. And group 3. Group 2 and group 4 are older patients. So, what is the full form? It is patient-oriented strategies encompassing individualized oocyte number. Giving names is a fantastic strategy, I think. So in group 1 and group 2, so let's look at one of the studies which looked at group 1A and 2A, produced less eggs, and group 1B and 2B, produced more eggs. The difference between group 1 and 2 is age, and thus aneuploidy plays a role. Group 2 patients will need more oocytes to get to 1 euploid embryo. Group 3 and group 4 are again, group 3 is young and group 4 is old. And if you look at the live birth rates, very, very different. Group 4 is very much someone where I think treating is going to be difficult. And one of the challenges is always going to be is trying to fine-tune these patients, aim to collect data, better classification, and eventually come up with a better plan. Drawbacks: Poseidon does not tell you which protocol is the best. It will give you a better platform and data to analyze best treatment options. So what should be the best strategy for ovarian stimulation? One is the shortest time to live birth rates and the lowest rate of complications. So what are the challenges you see with the poor reserve? What we know is that poor ovarian reserve fluctuates markedly between 5.6 and 35.1%. What is wrong with these patients? Reduced number of follicles, reduced granular cell function, reduced number of follicles responding to FSH. In some cases, which is Poseidon 3, you will see a low response, Poseidon 1 in fact, you will see a low response with good reserve patients. Possible genetic polymorphism, and a poor reserve does not have a single cause. So what I tend to do is I'll say, let's classify them into a classic poor ovarian reserve, or let's classify them into a hyper responder, which means that your protocol has been going wrong. In a poor responder, you've got somebody who's got a low AMH, low antral follicle count, and a low and advancing age. Poor stimulation means you are either stimulated with the wrong dose or you're stimulated at the wrong time. Now, often in poor response, it may be due to adequate FSH levels. And so I will often say, how many of you check the FSH on day 5 or day 6 of stimulation? And there are two reasons for it. One is that it gives you a general idea if the serum FSH is high enough. If the serum FSH does not cross 15, then either the woman is not taking FSH adequately, or in fact, for some reason, you are giving less FSH. And there are some women who will always have less serum FSH irrespective of the dose of FSH you give. I don't know the reason. But I often do a day 5, day 6 FSH, LH, E2, and progesterone because it gives you various ideas of how the stimulation is going. And often it gives you an idea about the amount of FSH you're giving. There seems to be a problem within the antral follicles. And how do we know that? Now you will see women with a low reserve having lower estrogen levels. What do estrogen levels signify? They signify mainly the granular cell function. And as women get older, the number of granular cells also starts decreasing. The ovarian aging process also decreases the number of theca cells and the number of granular cells. So if you start persistently seeing low estrogen levels, that goes hand in hand with poor granular cell function, poor number of quality of oocytes, because if you have less granular cells, you are more likely to get oocytes which are dark, which are less likely to get fertilized and reach a blastocyst stage. Should you downregulate for poor responders? The evidence is poor, and the evidence is, in fact, not poor, I'll say bad. Whenever you downregulate, you seem to switch off the pituitary and you tend to switch off the antral follicle count. So try what you want. If you're going to batch, your poor responders are not going to do well. You'll be lucky to get a few poor responders doing well. That does not really give you a better idea of what a large number of poor responders would do. Batching seems to work much better in good responders, in PCOS patients where results don't vary. In poor responders, you often see that your follicle count may go down. Now, let's try and use science to change the way we think about stimulation. Let's know that follicular recruitment is a constant phenomenon. It is not a follicular phase phenomena only. The peak of follicles varies in a cycle. And what you have to understand is, in a poor responders, the pool of recruited antral follicles may also vary. So the question is, it's not what you just give, it's when you give it that matters. It is when you start stimulating, and that can sometimes make a difference. So what we know from long studies is that women will recruit in a menstrual cycle twice or sometimes thrice, but they'll ovulate only once. Humans ovulate once, animals ovulate multiple times. But humans recruit follicles in a variable manner. When and how a poor responder recruits, it's something which you will have to decide. Now, what I tend to do is, I tend to look at the size of the ovary. And when you look at the size of the ovary, it will give you an idea. Small ovaries are less likely to have a variability. Ovaries which have a reasonable size, when you measure their size of ovaries, may have a chance of giving you a variable count. What we also know is that women start their recruitment in the late luteal phase. And so if you, in a 28-day cycle or a 26-day cycle, if you do ultrasound scan on day 21, 22, sometimes you'll see a better follicle count. Why? Look at the physiology. The FSH and LH in the late luteal phase is low. So what happens in downregulation? Exactly same parameters. You keep the FSH and LH low. And that probably gives you the best time to stimulate. So often I'll tell a patient, don't try for a pregnancy in that cycle. Why don't you come and see me around day 22 or 23? And if I see a good synchrony of follicles, a good number of follicles, we will start stimulation then, knowing that we may need to freeze embryos, because sometimes what happens is you start stimulation, within a day or two she gets a period, and then you can still do a fresh transfer if you want. But that's something which you can think about. Again, the general rule is that you get more blastocyst, you get your chance of getting a euploid embryo. And if you have a look at age, you need 4 blastocysts approximately to get 1 euploid embryo. By the time you reach 41, you need about 9 blastocysts to get 1 euploid embryo, which means, again, go back to the old research. You need more eggs. You need 20, 30, 40 eggs. Are you ever going to get it? The answer is no. Again, there have been more studies which have said that number of eggs in younger women, you require less eggs to get 1 genetically normal embryo. How can we get more oocytes? So let's go and understand a few concepts. Understanding a few technologies. One of them is called FORT, which is follicular output rate. Number of antral follicles, follicles that respond to ovarian stimulation. And this is again, any case, if you see somebody and you start stimulation, by day 5 you see that she had 12 follicles and 5 get recruited. That is a low follicular output rate. The other one is looking at the OSI. Again, that doesn't seem to make much difference. I tend to focus more on what is my recruitment. If I have 14 follicles and I recruit 5, then it is something based on the protocol or way the ovary is responding. And by day 5, I make a decision to say, see, if your follicles are of good number, but I can't recruit those follicles, there's something going wrong. Rather than saying your ovaries are not responding, I'll say, let's focus on the protocol. Women respond very differently to different medications, and sometimes I'll move from using HMG to using recombinant, from using recombinant to using a urinary FSH, and you can have that trial. I don't know which works the best. I know that recombinant in the first few days tends to give a much better response. That's because the recombinant molecule is much more powerful than HMG. HMG, evidence suggests, gives better quality of oocytes. If you look at the follicle to oocyte index, number of follicles at the end of stimulation, and number of oocytes obtained. Again, you get 15 follicles, 4 eggs. There's something wrong going on. Why do you get low follicle to oocyte index, low dose, genetic factors, asynchronous follicle development? So your follicles from 14 millimeter to 20 millimeter, and in that range you're more likely to get less eggs. And again, some technical issues. Type of poor responders, again, go back onto number 1 and 3, younger and older. So what are the options of treatment? The options of treatment could be dual stimulation, luteal phase stimulation, or random stimulation. So let's look at all these concepts. What is luteal phase stimulation? Start stimulation around the peak of the peak of follicular recruitment, that is generally in the luteal phase. Is there evidence? The answer is yes. There's very good evidence, mainly on cancer patients, where random stimulation works. If you compare between, in poor responders, between follicular phase and luteal phase, results were similar. In random start, where a follicle count is the best, results were probably best. Let's look at oocyte donors between day 2 versus day 15 stimulation, and you realize that the number of embryos preserved and pregnancy rates were very much the same. So quality of oocytes does not change when you stimulate. Then you look at a concept known as dual stimulation. The commonest questions I get asked is, oh, should we try dual stimulation? Because somewhere the concept goes that if you stimulate in the same menstrual cycle twice, you may get more eggs. How does it work? You stimulate in the luteal phase and you stimulate in the follicular phase. You don't give HCG as a trigger. Why? HCG luteinizes all follicles over 12 or 13 millimeter. So you're effectively going to lose those follicles. What does it teach us? It teaches us that follicles are constantly recruited. In poor responders, some follicles may be of better quality at both stages. Do not drain the small follicles at egg collection. Always use an analog trigger. And luteal phase stimulation has been used in cancer patients. So this came in RBM online, and I was at actually when this was presented. A lot of people laughed at this man's concept. And what he did is he started stimulating with clomiphene, letrozole, and used HMG, gave analog trigger, collected eggs. After a day or two, started giving HMG again, analog trigger, collected eggs. The results were brilliant, but after that, we have not been generally able to replicate that study. So, in effect, what do? You've got a picture like this, where you've got 3 follicles and you've got smaller follicles there. I think this meeting may end in 10 minutes. So, what you can do is you can start the stimulation both times.
If it ends, you log in at the same.
What I would suggest is start the stimulation only if you see small follicles 4 to 6 millimeter. Only then dual stimulation works. If you looked at his study, pregnancy rates were fantastic. Now, in my practice, I've never seen this work. I am generally against dual stimulation unless in those very few cases. So I'll tell a patient that it's unlikely that dual stimulation may work that well, will increase your cost, will increase the burden on you, will increase the discomfort on you. So I'm not a very great fan of that. Again, we're looking at dual stimulation, whether you tried a follicular phase stimulation or luteal phase stimulation, the quality of euploid. So again, try and identify what patient you've got. You've got somebody who has a variable follicle count. You'll be able to change how the woman responds. Simple logic, you can't stimulate more follicles than you have got. So often I used to see when I used to work in the NHS, now I don't, I used to see somebody scan and said there were 8 antral follicles and you got 15 eggs. And then we think it's magic. They do does a follicle contain 2 eggs? Now, if you have 5 follicles and you get 8 eggs, there are only 2 things that happen. Either you're a magician or you've got to stimulate, you've just scanned wrong. And often what happens is when juniors tend to scan, you tend to see those errors. I used to see that on the NHS where we used to see many of the juniors scan. In the private sector, I scan all my patients. So it's very unlikely that I'll be able to see such a response. So stimulate again when their follicle count is good. So what I would suggest is have a look at your follicle size. Follicles that are 1, 2, 3 millimeter do not respond to stimulation. Follicles which are 4 to 6 millimeter respond much better to stimulation. What is chasing the follicle? Scan at different times of the cycle. Whenever the follicle count is good, start the stimulation. How do I decide? I decide on the size of the ovary. The size of the ovary is small, you're not going to change much. And recently I had somebody who was 40 and I tried that for about 6 weeks. And eventually we got to 4 follicles, got to 2 eggs and 1 embryo. She's got pregnant very early. But again, just giving more eggs sometimes works. So if in this case you see on day 27, you don't see follicles. On day 5, you don't see. On day 12, you see a dominant follicle and you start seeing follicles. Remember, LH does not affect small follicles. So you can start stimulating again. What happens to the big follicle? You ovulate, but the follicles continues to grow. People ask me, is it possible? The answer is yes. Go back to physiology. What happens in the pre-ovulatory stage? The LH is high, progesterone is climbing, FSH is low, so estrogen is high. So how much drugs do you give? You always give a high dose. Why? Higher progesterone, higher LH. If you want to stimulate the smaller follicles, mild stimulation will not work. And so deciding that, It's one of the stages where I'll say always give a heavier stimulation. Again, I keep reminding, have a look at your luteal phase. Adjusting the dose in poor responders, does it help? They've done a study of that. Day 5, you see a poor response, increasing the dose, does it help? The answer is no, it doesn't. It makes no difference. Uh, do maximum strategies work? People have tried that. They have tried mixing heavy stimulation and mild stimulation. Doesn't work. Unless if you use random protocols, they just don't work. Should you increase the dose in poor responders? I don't think it makes a difference. Again, it all depends on when your follicle count is good. I think there is a general problem in some poor responders with their follicles, and routine stimulation does not work. If you look at the maximum dose of FSH is reached within 7.3 to 10 hours. Serum FSH reaches a steady level after 24 hours. That's the reason why you should do your FSH level on day 5. And once you pass those 5 days, there's little you can do. Can you do egg banking? That's one option. Embryo banking, yes. I think it's worthwhile. It increases cost. Finally, remember you can't change oocyte quality. Egg quality is beyond repair. Now, I'll just go up to a few slides on ovarian rejuvenation. I don't do them here. In the UK, it is not done. It's done in Spain, it's done in India, in all the other countries. So ovarian rejuvenation presents one. I may be logged off again. It says less than a minute, but I'll keep going. Ovarian rejuvenation presents an intriguing part. It is revolutionary. There's no doubt about it. The core concept is that women are born with finite number of eggs, but stimulating the ovaries, it may be possible to enhance follicular development, improve oocyte quality, and potentially restore some fertility. Uh, let's look at the physiology. Some of the primordial follicles and some of the preantral follicles often disappear. Can you activate them? Theoretically, yes. And where do you see that? You see somebody who's had cancer treatment, chemotherapy, and then they come back and the ovary rejuvenates. Why and how? Difficult to know. And ovarian rejuvenation is trying to address that. What are the various techniques? And they are platelet PRP, the commonest thing used, where you extract and concentrate platelet-rich and growth factors injected into the ovaries. Then there are stem cell therapies, mesenchymal stem cells from patients' bone marrow, injected into the ovaries. In vitro activation, surgical removal of ovarian tissue, activated with reimplantation of the ovaries, and exosome therapy. I've seen some patients of mine who go to Greece to have it done. And that's again uses infrared wavelengths or cellular messengers to support cellular function. This has been cut off, but what it tells you is that PRP probably has more evidence. The benefits are that potential benefits, minimal invasive, safety profile, you're using your own cells, potential of natural conception, consistent improvements in hormonal parameters. Limitations, it is still experimental. Long-term data is absent. There's no standard. You go to a conference, you learn something, you implement it. Patients are desperate. Patients are absolutely desperate for anything new. And they'll ask you, and we'll say, oh, it works. Now, you invest, let's say, 1 lakh of rupees to do it. Business suggests that you keep offering it to everyone. And so what happens is you offer it to all your poor responders. In private practice, data collection is poor. So you believe what you want to believe. And often it happens for all of us. We believe that a procedure works. So that's how, it's an age-old policy. What happens for thousands of years? Your doctor thought this works. And it's observational. And observational studies are not bad studies. Medicine has progressed. So you start offering it to all your patients who have got a poor response. Will it work? I don't know. I basically don't know. I've seen about 10 or 15 patients who've gone to Greece and come back. It's made no damn difference. They've wasted their money, I believe. But I may be wrong. And there is, you know, exists some hope. I think it will give us some proof as time goes by, as more and more data is collected. If you One of the clinics which has started doing it, is IVI. IVI as a center has phenomenal research backup, and which, if you see, they produce huge number of papers. And so, let's wait and see what people come out with. What you need is more studies. You need more understanding to a large extent. Eventually, you'll need a better protocol optimization and long-term follow-ups. Uh, some of it is promising, and some of them is very much marketing. So if you go on social media, you'll see a lot of people saying it works. Go to a conference and it'll say it works. So you're forced to adopt certain of these procedures. I'm not a person. I generally believe that there's a. I don't know how many of you all follow have read Carl Jung. Carl Jung was a Western philosopher, and he said a very sensible thing. He says, who is the person in the room who changes science, changes politics, changes everything? It's a joker. And a joker in the room will do something which is out of bounds, and eventually that will become a norm, and not always. And so, if you look at history, who are the ones who have changed science? They're the same people we are laughed at. If it was 1980s, we laughed at Kurt Sem, and we laughed at a lot of other people, and eventually they became people who changed science. And I believe that this may be one of those factors. So that's it. I'll take your question.
Any questions and queries anybody wants to put?
I get worried if there are no questions. One is either you've understood everything so well that you have changed entire medicine. You'll go back and say, I know everything now. My doubts have been cleared. And that I find more scary, because that puts me on a divine element. Or the other thing is, you say, what the hell this guy has spoken? It's gone
Just a moment.
complete bounce.
Sir, can you explain what are the difficulties you can face in a random start when compared to a day 2 start? Because since yesterday is that new introduction to random start for us, we want to know more and more. Like some conditions in a random start, you will feel I should not do this. Like LH, even though we think one dominant follicle has reached and is going to rupture, by the time these follicles also grow, the second set, will that LH will be there? I mean, progesterone will be there and will affect. Like we know as per the way you, sir, and you says random start is the best, but we need to know when we do hormones at that time, how will it look, which one we have to avoid, like that and all.
Yeah,
So, a few things. It's not that random start is the best.
Just an extension of the same thing. Just describe how you do antral follicular tracking and take decisions of starting the stimulation for these kinds of clients also. Just add on to the whole thing.
So, number one is it's not that random start is the best. What is best is when the follicle count is the best that you start. It doesn't matter. And then there are various scenarios. So let's say you scan somebody on day 10. Let's presume on day 10, you see 8 or 9 small follicles, and you see a dominant follicle at about 14 to 16 millimeter. So let's go back and say what happens physiologically at that stage. Your progesterone levels are low on day at 14 size. Your LH levels are not high. Your FSH is high. Can you start stimulating? Yes. At that stage, once you start stimulating, what do you need at that stage? You already have a high FSH. So if you give a milder stimulation, it's not going to work. So start stimulating on a higher dose. I always start with recombinant FSH, because one is it always recruits more follicles in the beginning. Now, your question is day 21, there's a corpus luteum. there is a high progesterone but a low LH. Okay, and that's what happens on day 21. High progesterone becomes a challenge at stimulation, which means that you have to push the ovaries very hard and they respond. What is the problem here? The only problem is where does random stimulation fail? If you miss an ongoing pregnancy. It's happened to me. So, yeah, what ends up happening is that you start stimulating and follicles start growing. Remember, even if you have got a pregnancy starts growing and the HCG starts climbing, and follicles start by 14 millimeter, follicles start luteinizing. Why? HCG has risen and HCG luteinizes follicles. That's one of the things that happen. And pregnancy is always important. So what I do is by day 5 of stimulation, I always then do a pregnancy test, an HCG level. An HCG level, you'll always pick up if an early pregnancy. So that is the only problem. Otherwise, it doesn't matter. Just if you have a high LH, so what? Just ignore it. Push the ovaries hard and follicles will grow. The LH will eventually decrease. So if you start the stimulation on day 14, we got an LH rise. The LH rise goes down. How fast? 24 hours, the LH rise is gone. 48 hours is the range of LH. So once the LH rise is gone, follicles will stimulate. So I don't think it matters. I think often you need to stimulate the ovaries well. If you have follicles that look of a normal size, I think they'll stimulate. How many I don't know, but they will.
Yeah, Anil, I'm just taking an opportunity here to have your view on something which is a common misconception. When you're doing IVF for a polycystic ovary, because she is a difficult polycystic ovary, like a very high LH or a high AMH, etc., what precautions you take and how do you start it off, like the doses and the choice of medications?
See, over the years, the only thing I fear is metabolic PCOS. I fear them tremendously. As I've got older, I'm no longer as courageous as many of the young people here. You know, I get a bit fearful, and I think it happens with surgeons also, isn't it? As you get older, you become a better surgeon, not because you can operate more, because you operate less. And the same thing happens with PCOS. I think the biggest challenge with metabolic PCOS is that you are going to get more immature eggs, you're going to get poorer quality blastocyst. And I always tell a patient who has irregular periods, who has high LH, who has got a high AMH, and he's got ovaries that are very large. I tell her, do not rush into IVF. That's one. Let's try and correct the insulin resistance to a certain degree. You may never be able to do it completely. I usually ask them to take metformin for around 6 weeks. I ask them to take minoxidil for 6 weeks. The reason is the evidence very good? Maybe. But do you have anything else to reduce your insulin resistance? The answer is no, you don't. So do something to reduce the insulin resistance. And then probably I start the stimulation. I usually follow a step down. And the reason is that the biggest challenge you see in PCO, large PCOS, is breaking the FSH threshold. I use recombinant only for 3 days, and then I use HMG. And the reason is, again, it tends to balance the recruitment, but you have to warn them that they will overstimulate. Even with an analog trigger, they will be uncomfortable. The outcome may still be poor. But that's what I do. I don't know how much research would back it. There are some reports that say if you give metformin for 3 months, you improve the insulin resistance in ovulation induction. I don't know if there's any evidence in IVF, but that's what I tend to do. My logic there is someone who has very large ovaries, who gets 2 periods or 3 periods a year. She's going to have a poor outcome. She's going to overstimulate. You have to do everything possible to try and give her a good outcome. The other thing which I use during stimulation, I always, in all my PCOS, use letrozole. One is because symptoms are less. Does it improve egg quality? I don't think so. Now, there's a study which I presented years ago by Nick McClellan's group. And what they did is they gave letrozole for PCOS throughout stimulation, and it kept estrogen levels low. But what happened is the number of eggs they got was one extra. But what I have seen in my practice is patients complain less. Uh, they falsely give you an idea the estrogen is low, so please don't use HCG. I've done that when I started this about 10 or 15 years ago, and patients went into bad ovarian hyperstimulation with low E2 levels. But I think the recovery rate is better. I continue post egg collection, I continue letrozole for 7 days, and I continue antagonist for 5 days. I see the recovery slightly better.
Okay, thank you. And what about poor ovarian reserve patient? Do you advocate any testosterone patches or any androgen kind of stuff as a pre-treatment? Any growth hormone in your practice or testosterone patches in your practice?
I don't give growth hormone. I'm not entirely convinced. And growth hormone costs about 200 pounds per dose in our setup. And I don't find the logic of giving it. I do give DHEA not because I believe it works. I believe that DHEA is a mild androgen. There is no doubt that if you give androgens to a woman with a small ovary, you're going to increase the size of the ovary slightly. And if you look at the theca element, I always say every visit measure the size of the ovary, because that will give you an idea if the ovarian size is increasing. It's a phenomenal, fascinating science. It's trying to understand. And so sometimes I'll use Testa gel, which is testosterone gel on the skin, about 7 days before starting. And I think there's some evidence coming in that favor. Androgenizing the follicles may improve the sensitivity. The logic is that who irritates women? Men. So if you put androgens in,
so true.
They will stimulate. I sometimes add letrozole too, because what does letrozole do? Letrozole does what DHEA and testosterone do. In the long run, letrozole does it in the short run. And letrozole increases intrafollicular androgens. So it's going to make the follicles more sensitive. I think it's trial. In some cases it works, some it doesn't. And what you have to, I'll tell my patients sincerely, I'll say, see, you're poor responder, it's going to be difficult. I'm going to try permutations and combinations. And some of them will work, some of them will not. And I think quite often patients, I don't mind if patients leave me and go somewhere. I would rather tell them the facts. Some patients don't like it. So be it, I'm not a magician, and I wish I was. I could touch the ovary and ovary size would increase. But I'm a medical man. I think we have to be frank and tell patients, see, it's not going to work. Or if I'm willing to try something different, do you have the patience to work with me? And often what happens is somebody loses patience. Often it's a patient who says, nothing's going on, this doctor is crazy, I'm wasted my time, and leaves. Fine. Sometimes you lose patience and say, come on, you're wasting my time. I've seen you 10 times and your follicle count is the same. Start. And sometimes it works out for both of us. And I've had a reasonable number of patients who it's worked, and equally a large number of patients where it's not worked.
Well, thank you so much, Anil. Thank you very much for all your inputs. And we're looking forward for you to join us for our journal clubs, which will be starting around 3 weeks or something. I will disturb you, take your appointment, and we will conduct a journal club also. So your advices during the journal clubs will be very important to all of us. Thank you so much. Thank you, Anil.
Okay, thank you very much.
Always
Bye-bye.
a pleasure to hear you. Thank you.